Okay, thank you. Good evening, everyone, and welcome to this webinar on the COVID vaccine and variants and what we can anticipate in the months ahead. My name is Barbara Drake, and on behalf of the Global Ministries team, which is sponsoring this event, I want to thank you for participating and to express our appreciation to our presenters who will be introduced in a few minutes. I also want to thank Reverend Dawn Taylor Storm, who has been so helpful in setting up this event. The Global Ministries team is a new committee this year in our conference, combining three former groups: the Church and Society Work Team, the Health and Healing Council, and the Missions Committee. The coronavirus epidemic is providing us excuse me, with a clear demonstration of how the work of these three previous committees is interconnected. The virus is affecting everyone, unfortunately, in a way, one way or another, in all of our churches and communities. As it poses a threat to our health, it is revealing, unfortunately, the racial disparities in the available, accessible, and affordable health care. And the virus is affecting people around the world who don't have the same access to vaccines as we do. This is challenging our missionaries and the hospitals and clinics we support in many countries. The Global Ministries team expects that this is the first of many health-related resources that we will be providing for the churches of our conference in the months and years ahead. And so now will you join me in our opening prayer? Loving God, our Creator, Redeemer, and Sustainer, we know that you care about all people and want abundant health for all of us. We thank you for helping the researchers who have been working on developing vaccines against the COVID-19 virus. We pray for all those who are providing medical and nursing care for the patients with COVID-19. Bring your healing touch to all who are suffering today. We thank you for the pharmacists and all who are involved in administering the vaccines and educating the public about the importance of taking the vaccines. We ask that you would bless our time together this evening. We pray that there will be no problems with the Zoom, and we pray that after the program is over, we'll all be prepared and willing to share what we have learned with those who need the information. We ask these things in the name of Jesus, our great healer. Amen.
Amen. We want to give thanks for the leadership of Deaconess Barbara Drake and for her team members who are on tonight. Two of the team members, there are others, but for Brenda Binns and for Reverend Jessica Ross, who will help with the presentation. It's my joy, friends, to introduce you to our speakers for tonight. They are friends of the Eastern Pennsylvania Conference. They have grown up in the conference and also been graciously not only sent from Eastern Pennsylvania, but are now transforming communities around our world. Dr. Elson Jacob is an assistant professor at St. John's University with a clinical residency practice site at Mount Sinai Hospital in New York, where she also serves as faculty with the inpatient family medicine and pharmacy residency programs. Dr. Elson Jacob is currently completing a master's in epidemiology at Columbia University. She is also the founder and president of the Coalition for the Advancement of Pharmacy Practice. Dr. Susan Jacob is an attending clinical pharmacist at the Massachusetts General Hospital in Boston, where she serves as preceptor for several colleges of pharmacy and the pharmacy residency program. Dr. Susan Jacob is currently completing a master's in clinical service operations at Harvard Medical School. Both received PharmDs from St. John's University in New York, and both are board certified in I'm going to get this wrong, Dr. Jacobs and Dr. Jacob. Pharmacotherapy, help me, geriatric pharmacy, and patient safety. They remain active in various professional organizations and in the community. Friends, you will be blessed by their sharing tonight. We ask that as they share, you share your questions with them. And so you'll find the Q&A that we invite you to use as they're sharing, and following their presentation, there will be a time for an answering of the questions that you have placed in the chat. I was so thankful when I reached out to Dr. Christopher Kurian to ask if perhaps Dr. Susan Jacob and Dr. Elson Jacob might be willing to share with us this evening. And they immediately both graciously responded with a yes. And so we give thanks for the connection at work for Dr. Christopher and Christy, Dr. Christopher Kurian and for Christy Jacobs, and for their daughters, Susan and Elson Jacob, for their willingness to share with us tonight. Welcome, Dr. Susan Jacob and Dr. Elson Jacob this evening.
Thank you so much, Reverend Taylor Storm, and we're so looking forward to speaking with you all about this topic. You know, it's such a joy to be back here in the Eastern Pennsylvania Conference, albeit virtually, of course, but it's amazing that we have the opportunity to do this in this format. So let me go ahead and share my screen real quick. All right, so I think everyone should be able to see that right now. So again, it's such an honor to be here with you all. So today we're going to be discussing vaccines, variants, and the road ahead. We know that this time has been so challenging for many of us here, and we're hoping to offer some words and some, of course, data to speak about the vaccines especially, so that those of you who might have some concerns about it could at least have the information and opportunity to ask questions, which we would be happy to answer. So really delighted to be here and looking forward to speaking with you all. So I just wanted to share that neither Susan nor I have any financial disclosures as it relates to this talk. Also, we are not representing the organizations that we work for the purposes of this talk. And of course, we want to note that we would encourage you to speak with your personal healthcare professionals if you have any specific questions as it relates to your health. So by the end of this talk, we hope to describe COVID-19, the way that it's transmitted and the way that folks present with the disease, also to summarize the vaccines, the ways that they are developed and the approval process, and finally to understand the vaccines that are currently available and how to prepare for the future, because of course we're looking forward to being out there and doing all the things that we enjoy to do. And so we want to discuss how to safely do all of that. So what we thought we would do is, use a case. So the purpose of this case is to describe a neighbor or a person in your life who may have questions about the vaccine and is, heard that maybe you got the vaccine or someone that got the vaccine and wants to know, some questions. And so we're hoping that by the end of this talk, you'd be able to answer some of these questions. So Robert, who is your 70-year-old neighbor, has diabetes and sees you on the sidewalk. And, of course, we're assuming that everyone is wearing their masks and standing 6 feet apart. And so Robert, slightly yells across the sidewalk and asks you some of these questions. So, let's have Robert ask some questions like, should I get the vaccine? I heard it hurts. What are my chances of getting COVID-19 anyway? He thinks he's pretty healthy. And it seems that these vaccines came out pretty fast. Will it affect my DNA? And finally, how do I sign up for it? So we're hoping that, we can go through some of the information here so that you'd be able to answer a neighbor such as Robert or another person in your family or a friend. So before we do that, I thought it would be nice to see the folks who are here and your experiences thus far. So I'm hoping that folks might be able to use the the hand raise feature on Zoom or type in the chat some of your responses. So how many of you know someone who had COVID-19? And you can raise your hand, or you could type in the chat as well. All right, so I'm seeing a lot of responses come in, and that's certainly a lot of hands. And I would also have to raise my hand there as well. And unfortunately, I think many of us do know folks who have gotten COVID-19. I personally know folks that I work with, my friends, and in our family as well, folks who've had COVID-19, and some also who had really bad outcomes as well. All right, so the next question is, who here has already received the vaccine? So I know that you might need to raise your hand again. All right, so it looks like we're seeing quite a few folks coming through with your hands raised, so thank you for sharing. And I would raise my hand there as well. So it's nice to see that many of us here have received the vaccine, and that's certainly encouraging. And who here plans to receive the vaccine when you do have an opportunity to receive the vaccine? I know that many folks have already received it. Looks like there's a couple of responses in about folks who are interested to get the vaccine. And of course, it's a phased process. And so, looking forward to, more folks getting the vaccine as you're able. So thank you all so much for sharing. So with that, I'm gonna move into discussing some about COVID-19. So we're gonna talk about the disease itself, go over some terminology, pandemics versus epidemics, transmission, and then how folks typically present with the disease. So coronavirus disease 19, or COVID-19, we all have heard about this, of course. We've lived through this for over a year and a half almost at this time. We know that this is a virus. It's the SARS coronavirus 2, or SARS-CoV-2 is the virus that causes coronavirus disease. And this is a novel coronavirus that was first, of course, identified in Wuhan, China in 2019. But it happens to actually be one of 7 coronaviruses that are known to infect humans. So some of you may have heard about some of the other viruses. So one being SARS-CoV-1, which you might have heard the term SARS, and that was the severe acute respiratory syndrome, which was first reported in Asia in February of 2003, and then that went on to spread across a few other countries, several other countries, and lasted till about 2004. So that was an epidemic. And there was also MERS, which is the Middle East respiratory syndrome, which was first reported in the Middle East, and it affected those in the Arabian Peninsula. And we also had lots of deaths with MERS, but it was also contained. And this happened in the 2012 timeframe. So the COVID, which is due to SARS-CoV-2, is not the first coronavirus to cause an outbreak. It's actually one of 7 coronaviruses known to infect humans. The other ones actually don't cause as much serious illness. It causes more flu-like symptoms, but it doesn't progress onto really the type of disease that we've seen with this particular virus. So the reason that this virus is named coronavirus, these viruses, are because of these spike-like proteins that are seen on the surface of the virus. So if you take a look at the picture on the right, you can see that this is the virus with these things that are sticking out, these spikes that are sticking out, and that resembles a crown. And that's why the coronavirus actually got its name, because it resembles a crown. And unfortunately, because of COVID-19, this has impacted many folks around the country and the world. So we've seen over 135 million global cases and over 2.9 million global deaths. And in the United States alone, we've seen over 31 million cases and over 561,000 US deaths. And unfortunately, in 2020, the COVID-19 was classified as the 3rd leading cause of death. So this has obviously impacted a lot of folks around our country. And many of us obviously know folks who unfortunately did get COVID. So just to go over some terminology. So there's this phrase that we all, we might be familiar with, but just to kind of go over some terms for folks who may not be as familiar. So the World Health Organization actually declared that COVID-19 was a pandemic, and this was on March 11th, 2020, so just about a year ago now. And so I thought I would talk about, well, what is a pandemic and how does that differ? Because we've also heard about this term epidemic. And the difference is that an epidemic is an increase in the number of cases of a disease. And this is more than what is normally expected. But a pandemic is that you have the epidemic, but it's infecting a lot of patients and across countries and continents. So it's a larger number of folks that were impacted by this particular virus. And that's why it was classified as a pandemic. So usually the World Health Organization makes the declaration of a pandemic because they're looking at the global picture. And that was actually declared last year. And since then, we've continued to be in a pandemic. So just some terminology there. And the way that this virus really spread and became a pandemic was primarily through person-to-person spread. So if you look at this picture, we can see that there are two humans that are standing, probably less than 6 feet apart. But primarily the way that the virus is transmitted is because of being closer than 6 feet apart. And there are these respiratory droplets, as you can see here, or that there are these droplets that are aerosolized that travel in the air and linger in the air. And if the next person who is not infected inspires or breathes in the virus, that's the way that it's primarily transmitted. So it's a respiratory virus where folks inhale the virus, and that's primarily how they become infected. But there's also some data around contact transmission. So if somebody were to have sneezed, and there's generation of droplets and it falls on a surface, and then pretty soon another person touches that surface, there's theoretically some chance for transmission that way. But really the primary way of transmission is person-to-person spread when people are in close contact and there are respiratory droplets that are produced when an individual coughs or sneezes. And then there's this concept about community spread, which is when you don't really know where you got the virus from, like you ended up becoming infected, but you have no idea where you got it from. And that's because there's a good number of people in the community who also are infected with the virus. And so people could have picked it up from any number of places. And so there's this concept about community spread. But primarily the mode of transmission is person to person through the respiratory route or through your lungs. So the key takeaway here is really the importance of social distancing, wearing masks, and of course, proper hand washing, and also, being cognizant and avoiding indoors without a mask as well. So that's, primarily what I wanted to discuss here, which I think a lot of folks here know this, of course, because, we've all been living through this for a year and a half now. So with just also, thought I would discuss very briefly the way that folks present or the symptoms that they experience once they're infected with a virus. So on the left side, you can see there's this severity of illness and time course, and it's talking about a lot of different stages. So I'm just going to just very briefly talk about it, which is that usually there's an early stage of infection, and this happens within the first few days of being exposed to a virus. And during this time, folks might present with a fever, a dry cough, and then that could progress on to the second stage, which is a pulmonary or a lung stage. And at this time, folks might develop shortness of breath, and then it could progress even more. And not everybody gets to the stage, but this is what we often hear about on the news, and from those in our lives, hearing if they ended up going to the hospital. Oftentimes it's much more serious, and at that time, folks might end up with this inflammatory response and have cardiac failure or shock, acute respiratory disease. And so this is sort of the phase, stage 3, which not everybody progresses to. But overall, this acute phase of illness lasts from between 1 to 3 weeks, depending on the individual. But what is what is not often talked about, and I think we're hearing more and more about this, is this late stage disease. So if you look at the picture on the right, we can see that there's a picture of a person and lots of different bubbles coming around them. But what I really wanted folks to take away from this is that we have these late sequelae or late stage symptoms, and these can last for months after. What we're seeing now is months after the initial infection, and people can still have this feeling of weakness and fatigue and headache and loss of taste and smell. So most folks actually over 3 weeks after the initial infection can at least have one of these symptoms of late COVID disease. And this is actually moving on to our next slide. You might have heard the term long haulers. So these are people who've really dealt with this disease for much longer than what we think of as something that's like an acute illness. But they're dealing with this for weeks and weeks and sometimes months after their initial presentation of disease. And so this is, as you can see, there are lots of different news clippings that we've included on the slide here. And this is just a fraction of what we see in different news outlets talking about how people have been feeling like this disease is taking a toll on their mind. They're feeling confused. They're having this fatigue that's lasting a long time. They're having this brain fog. And so this is really talking about these symptoms that can last a really long time. And this unfortunately can affect not just the folks that we are talking about who are most at risk, and we're going to talk about that in the next slide, but also folks who are young and would consider themselves, or they would consider themselves otherwise healthy. So this impression of, hey, I'm pretty healthy, I'm pretty young, and so I don't really have to worry about the diseases, unfortunately not true, because even if people did not have the acute illness to the stage 3, where they're having to experience really serious effects from the disease, folks can still have these long-term effects that we are still just learning about. So that's something to really pay attention to. So talking about risk, so who is most at risk? So this is really a question that allows us to recognize, well, who should we be immunizing first? And so when we're talking about the phases of immunization, it's really thinking about who's most at risk. So we know that older adults, and the definition for older adults, by the way, is like 65 plus. So older folks have more severe disease if they do end up getting the infection. So this is why those who are 65 and older are classified to be at a higher risk of the disease. Also frontline workers, so those who are really being exposed to the virus more often, so somebody who's working in a hospital, or those who are in a person-facing field. So these folks are also going to be at more risk because they're getting a more potential exposure to the virus. And then also folks who have conditions that affect their immune system. So sometimes we think of these folks as maybe those who have a history of cancer or an immunocompromising disease like HIV, for example. But actually, when we're thinking about the effects and conditions that can affect the immune system, we're actually thinking about conditions like diabetes, chronic kidney disease, those with chronic lung disease, heart disease, liver disease, cancer, immunocompromise, and other immunocompromising conditions. So it's really a larger variety of diseases that fall under this umbrella of conditions that can affect the immune system. So just something to recognize that folks with these conditions can also be at higher risk, and many of us do have some of these conditions. So that's why there's this risk classification again about who should be getting the vaccine first. And then those who are pregnant also do fall under the at-risk category. And this is because there have been studies and data that show that those who are pregnant can have more severe disease. And then those that are live in long-term care facilities, nursing homes, assisted living facilities, and the like. Also those who are incarcerated, and so institutions themselves are also classified at higher risk. And I just want to point out that this is just some of the criteria on the CDC risk for folks who are at risk. There's really like a long list of criteria that would state that somebody is at higher risk. So just something for us to recognize there. So I'm going to move back to our patient, Robert. And, so I'm going to ask you all a question. And usually we would do this format where the question's open-ended and you can actually hear everybody speaking. But for the purposes of this talk, I'm just going to ask folks to, raise their hands again or type in the chat. So your neighbor who's a 70-year-old and who has diabetes, again, sees you on the sidewalk, everybody's wearing their masks, everything is good there, but wants your advice on COVID-19, the vaccine. And so just ask the question, what are my chances of getting COVID-19 anyway? Question for the audience. So should Robert be concerned? So, I would like for you guys to raise your hands if you think that Robert should be concerned. All right, so it looks like there's quite a few hands raised. I certainly agree with all of you. So Robert does have, he would be classified as a high-risk person because of his age. He's older than 65 years old. And he also does have diabetes, which is classified as a high-risk condition with immunocompromising, that can be immunocompromising as well. So that's something that I would certainly encourage Robert to consider the vaccine, and also follow all of the other precautions as well. All right, so with that, I'm going to hand it over to Susan, who's going to talk about vaccine development.
Hi, everyone. Thank you, Alison. So in terms of the vaccine development section, we're going to be giving a brief history of vaccines and how important they have been, how important they continue to be, what are the components of the vaccines, how exactly do they work, what kind of testing went into the vaccines that we will be learning more about, and what is this thing we call emergency use authorization. Next slide, please. All right, so for a brief history on vaccines, so even though vaccines themselves had really been used in a variety of ways over 2,000 years ago, modern vaccination itself started in the year 1796. There was this British physician by the name of Dr. Edward Jenner, and he studied smallpox and found a way that he could use kind of features from somebody who had smallpox and was able to transfer it on to somebody else and allow them to get immunized, so to speak. And so that was a very rudimentary way, but that was modern vaccination, started out in 1796. So what was concerning was over 300 million deaths occurred due to smallpox in the 20th century. And today it is actually the only infectious disease. So there are many, many infectious diseases. And to this day, it is the only infectious disease that was eradicated in the year 1980. And that was declared by the World Health Organization. So vaccines themselves, many of us would have received childhood vaccines. So if we think of things like the diphtheria vaccines or Tdap, tuberculosis, there are many vaccines depending on where we grew up, where we live, and they have truly prevented disease and saved millions of lives. There might be some of us who remember the times of polio, where you may have gotten vaccinated. And in fact, the church bells were ringing when a vaccine had been found for polio. And I just wanted to highlight two little graphics here. You could see the introduction of vaccinations. You could see that diphtheria cases dropped once vaccinations were introduced. The same with polio, where we saw those drops as well. So truly, vaccines have saved millions of lives, prevented diseases as well. There are today many vaccines that are available, depending on the places we live. They're roughly a little under 30 vaccines. And if you're traveling to an area that has a particular disease that you might not be in the place or the country that you live in, you might have to get vaccinated for those as well. That is usually recommended by the CDC. All right, so why are vaccines important? So they protect us against mortality or death, as well as disease itself. They also prevent the spread of the disease, and we'll be hearing a bit more about that, and especially around COVID-19. And so the key is we want to prevent the spread of the disease. We want to save lives and truly also add to the number of folks who are vaccinated, because what this does is it contributes to something called herd immunity, which we're going to be talking about in just a second. Okay, so you may have heard this concept of herd immunity. What exactly is it? So on the diagram to the left, we have a person in the middle who's in red, and he has his circles around it. He is currently actively transmitting disease, so to speak. You have folks in blue who are healthy, they have not been vaccinated. And then you have a couple of folks in yellow who have been vaccinated or who are immune to the disease. And what happens, because we have a majority of folks who are not vaccinated, they're around this person who is sick, and now they are very likely, depending on the disease and how it spreads, how contagious it is, that is going to potentially spread to a lot of people, as we can see has happened in those on the right, where you have more people in red. So on the other hand, if we look on the second side of this diagram, or this figure rather, you can see that same person in red, but here now, instead of all of those people in blue who had not been vaccinated, we have more people who are vaccinated in yellow. And despite this person being quite contagious, it ends up being, because you have these vaccinated people, those folks who are in blue who had not been vaccinated, rather than all three of them getting the disease, and you see three people in red, now you only have one person. And what that means is, what the concept of herd immunity, just by those being around you who have been vaccinated, you're potentially protecting, giving indirect protection to those who are unvaccinated. And what does that mean in today's world? There, of course, yet we don't have children. Children cannot receive the vaccine, those under 16 at least. There might be a time when it might be babies or others who might not, for some reason, be, it might not be possible for them to receive the vaccine. So by getting vaccinated, not only are we protecting ourselves, we're protecting our family, we're protecting our friends, we're protecting our community. So anywhere between 50 to 90% of a population needs to be vaccinated or needs to be immune to a disease in order for herd immunity to occur. And that definition is really based on how contagious a disease is. So in the case of SARS-CoV-2, the virus that causes COVID-19, we need at least roughly 70% of the population to have been immunized or have immunity before we have this thing called herd immunity. So I hope that was able to explain what that concept is and why it is so important that when we have an opportunity to get vaccinated, we consider it, because as we said, we're protecting not just ourselves, but also those around us. Next slide, please. So what exactly is in a vaccine? So the vaccine itself has something called an antigen. It might be from the organism causing the disease, or something that looks similar to that organism. And that, in addition to various things like adjuvants or preservatives, stabilizers, surfactants, residuals, diluents. So these are basically things that go into a vaccine that prevent it, for example, being stuck to the sides of a vial. It prevents it, it allows it to be dispersed within the vial itself. You might be using diluents to get it up to the right amount. And so there are varieties of things. And because we've had vaccines around for so many years, billions of doses of vaccines have been made off of these components of a vaccine. So they're pretty well studied because of that. But the antigen itself might be different depending on the vaccine, of course. So that's really what goes into a vaccine. Next slide, please. So how exactly do vaccines work? So we have on the left, where I'm just going to give a quick kind of summary, so to speak, of what exactly a vaccine is doing. So you have the vaccine that you're giving to your body, and I think of it as some way for you to recognize an intruder. So you need to be prepared. You see something, and your body is getting prepared. Okay, I've seen this before, and now I'm getting ready. So it's almost like training for battle. Something that I want to keep in mind, these vaccines don't start working right away. It usually needs a couple of days for your immune system to start building up what is called antibodies, so that the next time your body sees this intruder, this pathogen, it knows what to do. So if you look on the right side, you encounter that disease again. So it's not going to be the exact same thing. It might just be like, in this case, Elson's going to be talking more about it. We're targeting the spike protein. That's what researchers so amazingly were able to isolate in this case and identify, and that's really all we needed. And so the next time your body sees that, identifies it, it knows what to do. It's going to have these antibodies ready to really go battle for you. And so that's how I look at what a vaccine does. And it's like training for battle, and then you're ready for battle the next time your immune system recognizes this pathogen. So something that is important for us to know is that these vaccines, there is no way it's going to cause the disease itself, just because of the components of it and how it's made. It's impossible for the vaccines, any of them on the market, to cause the disease. Those who would have there might be cases you heard about, folks who may have received one dose and somehow gotten the disease. That may have been because they already were infected and your body hadn't yet responded to the vaccine and build up those antibodies. So that's just a brief example, or explanation rather, of how vaccines work in our body. Next slide, please, Austin. So what exactly goes into the testing of a vaccine? So really there are 4 different steps, but multiple steps within them. So you have a preclinical phase where you're identifying the pathogen, identifying the antibodies, what exactly is needed to create this vaccine. Then in phase 1, we're really worried about the safety. So you're going to give it to volunteers who take this vaccine, and you're seeing what kind of a reaction. Is there an immune response? Is your body working against this? And is it safe? Those are usually a smaller group of people. And then in the phase 2 trials, that's going to be several hundreds, thousands sometimes, depending on the trial. And then, of course, in phase 3, we're talking about thousands of people. And at this point, really, they are the population who is going to receive that vaccine, receive the drug. The same testing happens in drugs and medications as well. And so you have usually, in the cases of vaccines, you usually have anywhere between 5,000 to 7,000 people who are studied before a vaccine might come to market. But there's usually a lot of robust studies that go into how have people responded? Have there been any complications? And if that ever happens, that medication that's been studied, you will never see it in market. There are, in fact, hundreds and thousands of drugs and medications that have been studied, but we will never see it because of safety and other concerns. Next slide, please, Austin. So the COVID-19 vaccine itself, what does that development look like? So on average, a vaccine development can take anywhere from 5 to 20 years. And why exactly is that? So there are a couple of reasons. First of all, it takes a lot of money to develop a vaccine. So it could be because the researchers the scientists have not received that kind of funding. They're still waiting for that funding to happen. Patient enrollment tends to be a very big factor as well. So these are volunteers. And so number one, you need people to volunteer for it. And number two, depending on the vaccine you're studying, you're going to only be studying it in the population that actually receives it. So if you think about COVID-19, many people are at risk, right? It's basically the entire world is at risk for getting this disease. And so that could be many people that could enroll in a study, and administrative approval and regulations. And of course, the manufacturing process itself can be very cumbersome. And so that is why it takes many, many years before a vaccine is seen on the market and in our arms. So in the case of COVID-19, it was really, truly, in many ways, a miraculous thing, because we had the funding available. There was immense funding because this was affecting the entire world. And so funding was not a limited supply. Just one second. Sorry about that. And so in this case, we had plenty of funding available. We also had thousands of patients. So in fact, for the Moderna trials, the Pfizer-BioNTech trials, as well as the Johnson & Johnson trials, we had over 30,000 volunteers receive these vaccines, or the placebo, which is not the exact vaccine. You're usually weighing one versus the other. And so we had many volunteers who had been part of these trials. So because of these, normally these issues we see arise, that was really taken care of in the COVID-19 vaccines. Sorry about that. And so because of that, we were able to have these vaccines developed in a very fast pace compared to what it normally would have been. And so the regulatory piece itself was not cut short. But we'll be talking about what that emergency use authorization piece itself was like. But the manufacturing, because of the type of vaccines these are, the manufacturing process too, it was actually quite speedy. And we'll be learning more about what that exactly is. So the emergency use authorization piece of this, so the Food and Drug Administration, or the FDA, is what evaluates all medical products and supplies, drugs, and in emergencies that are affecting many people, such as the current pandemic, you can have an emergency use authorization that is allowed for this product. And so that happened with these vaccines. They're still very stringently assessed before they come to market. And it usually happens because you don't have any other approved options. So just the next slide, I'm just going to show you briefly the many steps that goes into an emergency use authorization process. So not only do you have these clinical trials, you have safety data, you're presenting it before many bodies, before finally the emergency use authorization is approved. But in any of these steps, if there are any complications that are noticed, that will never go through. So that's just a brief overview of what the emergency use authorization process itself looked like. So back to our friend Robert, who's our neighbor who had some questions for you about the COVID-19 vaccine. So he asks, it seems the vaccine came out too fast. So should Robert be concerned about the speed of the vaccine development? So if you can perhaps type in your responses in the chat. All right. So thank you, Lenora. So yes, he should not. I can understand, folks that say this did come out too fast, but in many ways, this was actually a miraculous thing. Scientists had been studying the technology itself for many decades, as we'll be learning. But because of the number of tests, like I'd mentioned, usually for vaccines, you need 5,000 to 7,000 folks who are studied for these vaccines. But in this case, we're talking over 30,000 volunteers who had been studied. And also now, of course, we've had millions of doses administered. And so the vaccines themselves did not come out too fast because of the technology and the stringent processes that were in place.
All right, so I'm going to go over the COVID-19 vaccines, and I'm going to speak about the overall vaccine process and particularly focus on some specific aspects that folks might be interested in. So when we're thinking about these vaccines and wanting to understand, well, is this going to really be working, or what should I overall take away from it? Some things to keep in mind is the prevention of death, and that's a very critical piece, and prevention of hospitalizations, right? Because those are folks that come in contact with the virus and can potentially progress on to hospitalizations and or death. So that's something that we want to make sure that these vaccines really protect against. And then looking at overall efficacy. And then some things that we might want to keep in mind is the number of doses for a vaccine. But what I want to share before we talk about the individual vaccines themselves is that whatever vaccine you can actually get first is the vaccine that I would recommend taking. So I shared that, or I don't know if I shared this, but both Susan and I had the opportunity to get the vaccine. And I actually got the Moderna vaccine, and Susan got the Pfizer vaccine. And so we both got two different vaccines, and because we both work in the hospital setting, we did have the priority process for healthcare workers. But if I was offered the Johnson & Johnson vaccine, or down the line when other vaccines come out, if that was the one that I had the access to, that's the one that I would have gone for. So that's just something for us to keep in mind. And we can't really choose the vaccine that we want. I think that there's, depending on the place that you're signing up for, there might be a way to choose a certain day, and they might state the vaccine that's offered that day. But usually you're not going to be able to select the vaccine that you want. And in my case, I've read all of the studies, and whatever vaccine I was offered would have been the one that I would have taken. So with that, I'm gonna just go over, briefly the overall thought process with the vaccines, and how we came up with these particular ones. Not we, but of course the scientists. So the way that this really came to be was folks, when the pandemic really began, wanted to figure out, well, how are we going to really develop something that works in human beings, right? So now there's a lot of technology to figure out what the genetic sequence is for viruses and other animals, and etc. So the Chinese scientists actually had very quickly figured out the genetic sequence, and all over the world this technology exists, which, because of the pace of science, we can very quickly sequence viruses. And so we were able to, the scientific community was able to figure out what this genetic sequence of this virus was. And because of that, figure out strategies for the vaccine itself. And one thing that I talked about early on was that the coronavirus is so named because of these spike proteins that are found on the surface of the virus. So if you look at this picture here, you can see these little spikes that stick out. So that's really what makes the coronavirus quite unique and gives it that name. So, so we actually, because the scientists had the full genetic sequence of the virus, had the genetic sequence for the spike protein as well. So that was really became the target for scientists to utilize that spike protein. But just to kind of talk about historically, and Susan had gone over this, the old approach used to be, let's take the vaccine itself. Let's take the virus itself and use that to vaccinate, right? So the actual virus itself, and it used to be, I guess, killed, and then utilizing that same virus. But now the modern approach is completely different. It's next generation platforms. And so this inactive form of virus is not introduced at all. Instead, what scientists have been doing is to introduce a part of the coronavirus that is completely harmless and that serves as a marker or a flag. So when the body sees that small piece, it thinks that there is a foreign invader and then starts coming up with this protective mechanism. So as Susan described, it's like, arming up your body for a battle, right? So the body recognizes something is an intruder, and the natural response is to gear up for battle. So it's producing these antibodies. So for all of these vaccine strategies, it's really kind of utilizing that recognition of the spike protein and allowing for the body to develop antibodies. But here's the thing that's so incredible. The body never saw a foreign invader. So we really, what scientists did was to trick the body into gearing up for battle without ever seeing the actual virus, right? Because all it saw was a harmless piece of spike protein, and with that, armed up by producing antibodies. So that's the beauty of the strategy that the next generation strategies is really allowing for our body to create these antibodies that will neutralize a virus or a foreign invader without our body ever having seen a virus itself. So so that's really the overarching theme, and I'm going to go into the details around each of these strategies. But as you can see here, we have the Pfizer and BioNTech and the Moderna vaccines, which are the mRNA vaccines, and I'm going to talk about those details. There's also the Johnson & Johnson Janssen vaccine, which is based off of a viral vector. And then there's also Novavax, and the reason that I've included Novavax on this slide is because there's projection that this is probably going to be approved in the United States, and that's a protein-based virus. So we have, as of now, we have 3 vaccines, Pfizer, BioNTech, Moderna, and Johnson & Johnson Janssen that are available. And so, with this, we're talking about the Pfizer using an mRNA or genetic material to achieve vaccination. With Johnson & Johnson, it's really using a harmless, non-infectious adenovirus to accomplish the same thing. And Novavax is introducing a spike protein to then allow the body to produce antibodies and arm up. So now going into these individual vaccines, so I'm going to talk about the mRNA vaccines first, because this is something that we've heard about a lot, and folks may have some questions about this. So I'm going to try to go over some of the aspects that you might have heard about and maybe had some questions about. So the first thing to keep in mind is that mRNA, as the biology of mRNA, the potential for vaccines have actually been studied for decades. So when we hear about, there's these new vaccine and mRNA, we've never, this is a new thing and scientists just came up with it out of nowhere. That's actually, not true, because scientists generally work on stuff for a long time. And the reason I personally know this is because both Susan and I happen to both be married to scientists. And so, both of our husbands work in laboratories doing bench work and research. And so we see the amount of time and dedication it takes to actually get to the next step, because you're working really hard on something very specific. So there were actually scientists that are working on the biology of mRNA for decades. And that technology is what scientists were able to then utilize to come up with these mRNA vaccine. So just briefly, mRNA is a genetic material that the body uses all the time to make all sorts of proteins. So in the case of the vaccine, we are able to use a specific kind of mRNA that is modified and that codes for a small part of the coronavirus. So if you look at the picture here, so scientists take a small part of the virus, the genetic code or the RNA, the messenger RNA, that tells the cells what to build. And it's actually coated in this lipid so that it can easily enter the body's cells. So if you look on the image on the right, a person is injected with the vaccine, like I was, like Susan was, like many of you were, and the vaccine enters the cell and tells the cell to produce the coronavirus spike protein. So it's sort of like if you think about going to a restaurant, right? Like you might be the first step, and then there's this message that a waiter has to take into the kitchen for the cook to produce the dish, right? So you can think of it as the vaccine there, the mRNA is giving the message. So you being the person who's going to a restaurant and gave your order, and then the cook hears about it after that through the message being relayed, right? So it's this whole process of your body getting this genetic code to make the RNA, which is then the message that then produces the spike protein. And like I had shared previously, this spike protein is harmless by itself. It actually has to be on a virus to cause an infection. The spike protein in itself, it's just a very clever strategy because the protein then alerts the body that there is an intruder, even though there actually is not a real intruder. And then the body develops these antibodies to fight this infection, which there's really no infection, but the body's like arming up for battle, with just a spike protein. And so these antibodies are developed and ready to fight the infection. So if that person were to come into contact with a virus, there's antibodies ready to fight. So that's sort of like the overall understanding of the mRNA vaccine is, really gearing up the body for if there is exposure to the virus. So the other question is, does this integrate with our DNA? And the answer to that is also absolutely not. Actually, if we were to think about the mRNA itself, once it's introduced into the body and after a few hours, it's actually degraded. The genetic material is completely degraded. So it does not integrate into the DNA. There's actually no way that can happen. But just in case any of you had heard about this, because I know there's a lot of information, and I've seen a lot of different information out in the news or on social media and things like that. And so it's just important for us to realize that it does not integrate into the DNA. What it uses is this really incredible technology, and all because we actually have the genetic sequence, and we know exactly what the code is for just the spike protein, and the body's able to manufacture the spike protein. And then the body is then able to create antibodies. And that's really how mRNA vaccines work. So I thought this was a really cute cartoon that's a little silly, but maybe it conveys the message in a humorous manner. So you can see this most wanted poster, and there's a picture of a spike, right? It says COVID-19 spike protein, armed and dangerous. And that's true, it actually is a dangerous virus, of course. And then you have all of these like antibodies running towards this intruder with the spike protein. So that you can think of the mRNA vaccine is like the most wanted poster that tells your body how to recognize COVID, because hey, you're seeing it right here, you're seeing the intruder. And that's kind of how the antibodies really go after a virus if it were to come into your system. And it really cannot, and it won't change your DNA. So the next strategy was this viral vector vaccines, and also an incredible scientific feat as well. So this is based on an adenovirus-based vaccine. And just to kind of talk about this a little bit more, so the Johnson & Johnson team used a modified adenovirus, and for adenovirus, for those of you who may not be as familiar, is a cold virus that does not cause severe disease, but can cause a cold. But they used a modified adenovirus that actually cannot cause disease. It cannot cause a cold. It cannot cause flu-like symptoms, but they use that. And they modified it. And this virus can enter cells, but it cannot replicate or cannot duplicate itself inside a cell or cause an illness. So this was the strategy that was used for viral vectors. And actually, just for folks who may like some fun facts about this, this is actually not the first vaccine that was used with the viral vector technology. It's actually, there's a vaccine for Ebola that was also made by Johnson & Johnson. And there are trials being run for other diseases as well, like Zika and HIV. So these adenovirus vaccines are actually more rugged than the mRNA vaccines from Pfizer and Moderna. So the DNA is not as fragile as mRNA. And the adenovirus has this protein coating that allows protection of the genetic material on the inside. So it actually makes it more robust in the sense that from an operational sense, these vaccines can actually be stored for longer and at higher temperature. So it's not as fragile. But here's the other thing. People wonder, like, can this also be incorporated into my DNA? And that's also not true, because the DNA is actually degraded after the message is delivered. So it's actually kind of doing the same thing. So if you look at the picture on the right, you see this adenovirus that enters into the human cell, and it's kind of engulfed and it's kind of taken to where the nucleus is. And here the DNA is converted over to mRNA, and the mRNA then allows for production of the antibodies, which are proteins. So it's sort of like the same sort of overarching downstream effects of producing antibodies. So that's sort of the difference between mRNA-based vaccines and the viral vector vaccine. Okay, so when we're talking about what is available in the United States, so we have Pfizer-BioNTech, which are mRNA-based vaccine, Moderna, which is also an mRNA-based vaccine, and Johnson & Johnson, which is a viral vector-based vaccine. So the overarching differences here are that for Pfizer and the Pfizer-BioNTech, they are two separate shots and they're given 21 days apart. And they did achieve emergency use authorization, and these can be so far utilized in those who are 16 and older. With the Moderna vaccine, this is also a 2-shot series and they can be administered 28 days apart. It also received emergency use authorization, and this vaccine can be given in those 18 and older. And then the Johnson & Johnson vaccine is a single shot, and this also achieved emergency use authorization and can be given for those 18 and older. So when Susan talked about the very sort of impressive enrollment of over 30,000 folks per vaccine, that really we've never seen numbers like that. And as as healthcare folks, we read trials all the time, and those kind of numbers we don't see in clinical trials. And other vaccine trials, usually you're seeing like 6,000, 7,000 on a good day, right? So seeing 40,000, 43,000, 30,000, it's an incredible number of folks underwent the trials for these vaccines. And here's the thing, that was just the trials. Since then, folks have continued to study the data around those who received the vaccines. And as of April 10th, so a couple of days ago, 183 million doses of COVID-19 vaccines have been administered. So it's an incredible number of folks. And so we have a lot of information about the ways that folks react to the virus, the protection that it provides. And I just wanted to say a couple of things about this before going into each of the individual vaccines and the details. So the key to think about this is that in order to achieve full vaccination, to feel like you're fully vaccinated, it has to be 2 weeks from the last dose. So obviously it's going to take a little longer for Pfizer and Moderna because you have this 2-dose series, but it takes 2 weeks after the completion of the final shot for folks to be considered fully vaccinated. And the other thing I want to point out, just because I've seen, I'm on social media, we're all seeing a lot of these messages out there. There's actually no evidence that the vaccine causes death. Any of these vaccines cause death. So the reason I want to bring this up is there's a lot of concerns about this, and rightfully so. We should be really, reading about these things. We should be thinking about it. We should be asking questions because it's, ultimately our bodies, and we want to make sure that we're making the right decision for ourselves. So with these vaccines, when there are reports about adverse outcomes, meaning something bad happening or somebody passing away, that's the time when outside reviewers, meaning people who are not, not part of the drug companies and whatnot, take a look at the data to see, well, what is going on? What are these deaths? Like, are they related to the vaccine? Are they related to the drug? And what they saw is there were about, I think it was 2,000 deaths total. And they looked into these individual cases, and there was no relationship with the deaths and the vaccines. So it's, if you're thinking about 183 doses, and you can think of like, half of those maybe being people. In a given period of time, you're going to have people pass away from lots of different reasons or have negative outcomes for lots of different reasons, unrelated to the intervention or the vaccine or whatnot. So what they saw is that there was 0 cases of death that was directly related to the vaccine itself. And that is incredibly reassuring, especially as somebody in the healthcare field and someone who takes care of patients, to discuss, because this is a very serious question that folks have. And what the data shows is that there is no evidence that vaccination causes death. So now going back to our friend Robert, who has diabetes, who's 70 years old, who asked your advice. He wants to know, will this affect my DNA? So feel free to type in the chat if you think that yes or no, if we think that it's going to affect the DNA for Robert. All right, so I see some answers that say no. So it looks like most folks are saying no. And yeah, and I agree. And again, as somebody in the health field, right? Like it's something that I get asked a lot by patients and my colleagues in healthcare and others, family and friends. And so that's something that that we really try to help folks come up with an informed decision about medications or vaccines. And so that's something that we know a lot of folks have questions about. And so looks like folks have most, everybody that's written in the chat has said no. So great. Okay, so moving on. So I'm going to talk about each of these individual vaccines that are approved in the United States. And I just want to point out that there are other vaccines that are approved in other parts of the world that, that folks are utilizing. And so, this obviously with our audience mostly being from the US, just want to point out that we're going to be focusing on the US vaccines. But I know that from my understanding that there might be folks from all over the, even maybe from outside the country listening as well, in which case, this obviously the wonderful thing about Zoom and the opportunity to present in this way is, having the opportunity to interact with those from across the country and the globe. So, happy to answer questions broadly as well. But we're going to be really focusing on the vaccines approved here in the US. So the first is the Pfizer-BioNTech vaccine. And this, again, is an mRNA vaccine, which received approval, emergency use authorization on December 11th of 2020. And folks that are 16 and older are able to receive this vaccine. And just want to point out, because I know that there's potentially parents in the audience and others who may wonder, there's actually trials that are ongoing. There's a childhood trial that's been initiated and also an adolescent trial that completed. And so we're waiting anxiously for the data around that. And the number of shots are 2 shots, 3 weeks apart, and the overall efficacy is 95% from clinical trial perspective and 91% for real world. But really more importantly, when we're thinking about protection from severe disease, it's 100%. Also hospitalizations are 100% protection and death also 100%. And the side effects, so most folks are going to experience some side effects. And I can say personally, I got the Moderna vaccine, but I had a sore arm for 3-4 days after the vaccine. And I felt like maybe like somebody gave me a little punch. So it hurt for a little bit. That's very common with vaccines. And also most folks experience a little bit of tiredness. So I was tired for a couple of days and then I felt completely back to normal. I didn't have a headache, but some folks do experience headaches, some muscle aches, chills, fever, which some folks do experience in lower percentages, but can happen, and joint pain as well. So these are, to be expected. And then moving on to the Moderna vaccine, also an mRNA vaccine, which received emergency use authorization on December 18th of 2020, can be used in 18 and older folks. Here, there's also adolescent trial is ongoing, and a childhood trial has initiated or started. And just want to say that, again, we're anxiously awaiting these results. And once we have that, then we're going to see changes in who can actually receive it. But we're waiting to see what those results are. And there are 2 shots again. The efficacy here is 94.1%, which is also incredible. So just keep in mind that when we're thinking about other vaccines, what we think of as amazing is like 50%, 60%. So seeing 94.1% is mind blowing. So that's, incredible percentages of overall efficacy. And then we're seeing protection from severe disease, hospitalization, and death. It's 100% for all of these. And again, same types of side effects noted here. And, I can say from personal experience, like I mentioned, that I also had some of these and expected it as well. And then with the Johnson & Johnson vaccine, it's a viral vector vaccine, and it was approved in 2020 on February 27th. And this is approved in those 18 and older. And the really great thing here is that it's a single shot. The overall efficacy was 72%, which is also really good. And protection from severe disease, hospitalization, and death were 85%. From severe disease and 100% from hospitalization and death, which, as I mentioned at the start, that's really what the most important thing is, keeping folks out of the hospital, keeping folks, from passing away from COVID-19, because the concern again is folks becoming intubated or having a negative outcome. So seeing that that's 100% across the board is also, really incredible as well. And the side effects are very similar to the other vaccines. So injection site pain, headaches, fatigue, myalgias, and nausea as well. And actually, I did want to point out one other thing in case some of you are wondering. So there's another vaccine that folks in the UK and other places are receiving, the Oxford AstraZeneca, which is similar to this vaccine. And there's some news around blood clots and things like that. So for the Johnson & Johnson, there's many people who underwent the trial and many people since who received the vaccine. And I believe there were 4 cases of blood clots that were identified. And when looking at each of those individual cases of blood clots, what they saw is all of those folks none of those folks who had those blood clots were related to the vaccine. There was actually one of the persons had a clotting disorder. And the other folks were also not thought to be related to this vaccine. So in case folks who may have had that question. All right, and as I mentioned, there's a lot of other vaccines out there for trials. So, just to kind of give you a global picture, there's 50 vaccines in phase 1, 35 in phase 2, 23 in phase 3, 5 that are authorized for early use, 3 of which are in the United States, 8 that are approved for full use, and 4 that were actually abandoned because there were adverse effects or for various reasons. But beyond that, there's beyond the ones that are approved, there's probably many others coming in the pipeline. But this process of getting approval is incredibly stringent and very controlled. So that's just something for us to see what's in the pipeline around the world. And then also thinking about from a global picture. So this again, this data is from a few days ago, and I know that there has been some changes, and I'll talk a little bit about that. But if you look at this, the United States sort of falls in the middle of the, more towards the top, but not exactly all the way at the top. So you can see that for those who are vaccinated in the country, Israel has really high percentage of vaccination that's over 60%, and the UK is over 40%. The Chile is close to 40%. The US is hovering around the mid 30s. So there's 178 million doses that folks in the US received as just single dose so far. And so that's really, we're kind of chugging along. Hopefully we'll see more and more numbers and percentages of folks who are able to get access with it, which we of course know there are phases and each state is kind of doing their own thing. But we're hoping to see higher numbers. And actually just a couple of days ago, some of you may have heard this in the news with Bhutan, which had really high numbers, after vaccinating most of their population in a week. And of course, they're a lot smaller country than we are, but so some of these numbers are of course updated, even though it's just a couple of days ago. So it's incredible how fast the news changes with with COVID and the vaccines. So now we're coming back to our patient, or neighbor rather, Robert. So, you know, he wants to know, should I get this? I hear it hurts. So I want to know what folks think. So, you know, raise your hand if you think Robert should get the vaccine, or, you know, feel free to type in the chat as well. So it looks like I'm seeing many hands raised. So it's nice to see. And, you know, and I would agree. I think Robert should consider getting the vaccine. Of course, if there are any questions, you know, he could ask a pharmacist or a physician or other healthcare provider. So, all right, so perfect. So moving on to special considerations. So there are lots of questions about children and older adults and pregnancy and lactation. And so we thought we'd go over that quickly. So children, of course, make up over 20% of the US population, or approximately 20%. And there's been news out there about, you know, folks and, you know, what these conditions that children are experiencing. So even though infection in children is uncommon and generally mild, there are these rare cases of hospitalization and multi-system inflammatory syndrome, which is of course very scary for parents and children. So that's something that we're keeping an eye on. And there's promising data, of course, coming out. The Pfizer BioNTech is approved in 16 and plus folks. So children who are 16 and plus can receive the Pfizer vaccine. And there's also several studies coming up with Pfizer and Moderna. So we're waiting eagerly for that. So the hope is that children will be eligible by the 2021-22 school year. So that's something to look forward to. And with older adults, of course, there's increased likelihood for severe disease. And so the recommendation is for folks to get the vaccines. And there's actually something very promising, which is that older adults have reported lesser side effects from the vaccine when compared to younger folks. So that's something you know, very interesting, and something that all of the trials have reported. And then moving on to pregnancy and lactation, because you know, I know that several friends who are pregnant or wanting to get pregnant have approached me about this. So there's actually more severe illness and adverse outcomes seen in folks who are pregnant from COVID-19. So there's this concern about that. And there is also, but the good thing is that over 30,000 pregnant women have actually received the vaccine. So that's very promising. And the data that we have so far of those who've volunteered to get the vaccine is very, very promising. The animal studies were, you know, there were no safety concerns noted, but the clinical trials and the clinical data shows that not only were the moms protected, but also the fetuses were also protected as well. So that's something, you know, really incredible, that the babies, the unborn babies, were also protected. And then when we're thinking about lactation, so there's no risk that we're seeing so far with breast milk. So in fact, trials show that there's protection of the child if the mom is vaccinated when you're thinking about lactation. So that's also with breast milk. So that's also very promising data. And there's also no adverse effects or nothing negative seen from a fertility perspective. So for those who want to become pregnant, that's something to realize as well. So there are these big societies that have put out recommendation, with the major one being ACOG, which is the American College of Obstetrics and Gynecologists, and also the CDC and FDA and others. And they actually recommend that folks who are pregnant or lactating also receive the vaccine. So with that, I'll hand it over to Susan for planning for the future.
All right, thank you, Alison. So we'll be talking about what's involved with signing up and preparing when getting the vaccine. What are these variants we've been hearing about? What to think about when we talk about gatherings and travel. All right, so going back to our friend Robert, he asked us, how do I sign up for it? So we're going to hopefully be answering that question in these next couple of slides. So signing up for the vaccine itself, one thing that I think we both would want to emphasize is the vaccine is completely free to anyone who is eligible. You do not need health insurance in order to receive the vaccine, nor do you need legal documentation. So that is important for many in our society to know about. You can check with your physician, your pharmacist, community health centers regarding the availability of the vaccine. The state or local departments should also have more information on this. And when it comes to signing up for the vaccine itself, you can go to vaccinefinder.com, which should list out to you where within the state you can sign up. You can also check on your local pharmacy's websites. News outlets usually have this information as well as the state health departments. So before the vaccination, there are a couple of things we want you to keep in mind before the vaccination, during the vaccination, and as well as after. So before the vaccination, something that's important for us to keep in mind is try to avoid taking any NSAIDs. So we're talking things like ibuprofen, Motrin, for example, Tylenol, because there is some data that shows that this might reduce the effectiveness of the vaccine. Avoid taking things like antihistamine. So this is like diphenhydramine or Benadryl. And the reason why we make this recommendation is because it could potentially, because of the way these medications work, it could potentially mask an allergic reaction, which if you might run the very, very small risk, but if you happen to be that person who might have an allergic reaction, you don't want to potentially mask it and then go home and potentially have something happen. And so we would recommend you avoid taking that antihistamine. Of course, when you are getting the vaccine itself, try to relax your arms so that you have a little less soreness, perhaps. And all folks are going to be staying for at least 15 minutes, at least for Elsa and myself, we had to wait for about 15 minutes to get monitored to make sure, because most people will have, if you had an allergic reaction, it would happen during that time, which is again why we make the recommendation to avoid an antihistamine, because if that were the very rare chance that it did happen, you would want a healthcare professional to observe you and to take any necessary steps. And so that's going to be during the vaccination. After the vaccination itself, you can expect, like Elson mentioned, so there's some mild to moderate symptoms that folks can experience. It could take 2 to 3 days. I myself had a little bit of an arm ache that lasted for about 2 days or so. You can take at that point pain medications such as Tylenol or NSAIDs, like the ibuprofen I mentioned. But of course, this depends on the patient. So we're not making that kind of a global recommendation for folks who might have kind of conditions that your physician, your provider has recommended you not taking those medications. Obviously, we'd want you to check with your healthcare provider before taking those medications. The risk for infection, so in terms of the vaccine itself, we talked about the immunity. Usually you're going to want to give yourself at least 2 weeks or so after your last dose to really have the immunity that is promised from the vaccine. But the risk for weeks after, for transmitting the virus, we actually don't know the data. So even if you're vaccinated, you might potentially be transmitting to somebody else. You yourself will not have the disease, so we don't know that. And so there are some recommendations on the CDC provides on what you can do, which we'll be going over in a bit. A lot of places are handing out vaccination cards, and we would recommend you to hold on to that. And that is because depending on where you travel, they might actually ask you to show that. So we'd recommend that you hold on to that. So what can you do once you've been vaccinated? So the CDC actually has this on their website. And I'm just going to briefly go over this for us. So you can, according to the CDC, you can visit inside a home or private setting without a mask with others who are fully vaccinated of any age. You can visit with one household of people that are unvaccinated who are not at risk for severe illness, and that you can find that list on the CDC's website. It's similar to anybody with an immunocompromising condition or some kind of a condition that might make them at a higher risk. You'd want to really pay close attention. You can travel domestically. You can also travel without quarantining after travel, and you can also travel internationally without a pre-travel test. Of course, depending on your workplace, you might, like my workplace, you would still want to show that that you don't have COVID-19 when you come back. And so you'd want to follow what your workplace or wherever you're going makes a recommendation towards that. You can also travel internationally without quarantining. But on the other hand, when it comes to visiting indoors without a mask, that is not recommended. It's also not recommended to attend medium or large gatherings. And I just want to keep in mind, some of these recommendations might change as the time goes on. So you want to really be paying close attention to these bodies like the CDC and the recommendations they make. Okay, so when it comes to planning for church, This is off of the CDC, and it's also off of the, I believe it's the Wisconsin Council of Churches. And so we just broke this up into unsafe to gather, what makes it safe to gather, and what is it safest. And so I'm going to start out actually with the make it safer category, and we'll kind of walk through this, and we can answer any questions that you have. So we had talked a bit about herd immunity, and you'd want roughly about 70% of the population to have been vaccinated in order for us to experience herd immunity. And because of that, it would be safest, for example, to have at least 70 to 85% of our population to have been vaccinated. But if it's safer, would be making it safer would be 50 to 70%. When it comes to viral transmission itself, ideally, the safest category would be to have cases less than 1 per 100,000. And you can find that on your state's website. And you'd want a positive test to be less than 5% for it to be safest, or less than 10% for it to be safer. So I'm going to actually go in the next category. I'm going to talk about the bottom section of the middle part, just because that's going to apply for the safest options as well. So face masks, you want to make that mandatory. Physical distancing, so usually that's at least 6 feet apart. Low touch environments, meaning you'd want to avoid things that people are passing along, such as the offertory plates and such. You want to try to see if you can shorten your time of service. Outdoor or increased air exchange would be preferable. Singing by worship leaders only. Focusing on sanitizing high-touch services, and sign in attendance list just so that you know who else has been there. But the safest option would be all of these things that I just read. A hybrid or phased out plan would be recommended. You want to at least wait 1 month between phases. Have strategies for what a fallback plan might be if there was an outbreak at your congregation. Have a communication plan in place, as well as team responsibility. I'll just quickly go over when is it unsafe. Obviously, if your vaccination rates have been less than 50%, it is considered unsafe to gather. If the transmissions with cases are greater than 10 per 100,000, positive test rates of 10%, you wouldn't want to have everybody there at once, or unmasked without social distancing at full capacity, singing together, because as Elton had mentioned, this is a pathogen that is transferred in an aerosolized manner, or droplets. And so ideally, you want to have people still fully masked and preventing any of that potential transmission. And of course, you want to avoid eating together as well. All right, so we're going to be going into variants, but we thought it would be nice for you to see this slide, just because you have a speeding train ahead with COVID cases, and then you have the variants on that first car. And the thing that's coming towards it are the COVID vaccines that we are try to speedily get into as many arms as possible. So the race against vaccines and the variants are ahead. And so this is something that we should be paying close attention to. All right, so what exactly are these variants? So the nature of viruses itself, they are constantly mutating. These viruses are finding ways to evade our immune system. They're thus mutating so that it can obviously cause the disease that would be taking place because of these viruses. And that is why there are always going to be variants and mutations. There are multiple variants that have been discovered with COVID-19, and it can affect even young and healthy folks. So nobody is really immune to potentially getting this COVID-19 disease. So that's something we should all be keeping in mind. There are 5 variants of concern. There are different labelings by the CDC, but there are 5 variants of concern, and they're classified in this manner. There are very specific specifications on how these classifications take place. But essentially, they spread fast, they are spread easily, and they can cause severe disease. And these are basically what makes it a variant of concern. And we have listed for you what those 5 variants that are currently concerning are. And studies are still investigating how they spread, what their pathogenicity or their ability to cause diseases, how the vaccine's effect on them are, and if we will need a booster shot. So that is still being studied. And so I'm going to quickly go over the variants that are currently on the scene that are of concern. So we have the B117 out of the UK, the B1351 out of South Africa. There's a Brazilian variant, and then there are 2 variants that were first detected in California. And they've all been in the US either since the end of December 2020 or early 2021. And in fact, the B117 out of the UK is actually now the major variant strain that is available. or present in our community. So in terms of some things for us to know, the B117 is 70% more transmissible. It's also 55% more deadly. The vaccine is still effective from what we know. The South African variant, it is 50% more transmissible. We don't know yet if it's going to cause more severe disease. And from what we can see now, there are reduced vaccine effectiveness. The P1 or the Brazilian variant, it's likely more transmissible. We are still learning if it causes severe disease. There is potentially reduced vaccine effectiveness. And the two California variants, they're 20% more transmissible. Unknown if there's severe disease, and the vaccines are likely still effective. And the reason why we wanted to just show you what these variants are, first of all, we will potentially be discovering other variants as they come onto the scene and we learn more about them. Studies are still discovering their transmission rate and the effectiveness on the vaccines and how much they can protect us against it. But something to keep in mind, there are 5 states that are causing 45% of the new overall cases in the US. And actually Pennsylvania is one of those 5 states. And in fact, the B117 variant is the highest rates are seen in these states as well. So this is just something that I think we should all feel fairly concerned about, just because the key thing for us to keep in mind that can curb this disease as it is now is for getting as many people to take the vaccine, because that is what's ultimately going to stop the spread. It's going to stop these viruses from mutating and curbing the pandemic. And that is essentially, I would say, our hope is to get those vaccines in arms. Next slide. So just thought that this was a cute cartoon for us. Hopefully one day we'll have a future where, in this case, we have a kid who's being read to. The princess received her second vaccine and was able to go to balls again. Hopefully that there is a day where we feel as a society we are comfortable going out and it's safe for us to finally go out and do the things that we enjoyed with all of the folks that we want around us. All right, next slide, Austin. So the main takeaways from our talk that we hope we can leave you with: COVID-19 is a preventable infectious disease. It can present as a serious disease, and it can, as we learned, have long-term effects. The vaccines itself, the ones that are currently being utilized, they have been well studied. Vaccination will protect you, not just you, but also those around you. Our understanding of the virus continues to develop, and I think we're going to continuously learn more about it. And we encourage you to continue. All of us should be continuing to wear our masks, socially distance, wash our hands, and take other precautions. All right, and with that, we will open the floor to any questions that you might have. I know that a couple of questions came through, and I was we were trying to answer some of those. I'm happy to read those out, or I will open the floor, and maybe our moderators can also join us.
Brenda, do you want to begin?
Okay, yeah. We actually had the first question. It was in the chat screen, and it concerned one of the new strains. And the question was, I recently heard a new strain might be able to break through the Pfizer vaccine. Can you speak to that?
Do you want me to answer? Do you want to answer?
Yeah.
Okay, so I think the key thing to keep in mind is that with these vaccines, if you did receive one dose of the vaccine, you have a certain degree of protection. So even if you were in contact with the virus, you're going to have less, even with a mutant, a variant, you're still going to have less of a severe disease. You might still have some of the, like flu-like symptoms and whatnot, but there's a less likelihood for ending up in the hospital or death, right? So that's sort of like the promising thing with a lot of the vaccine data, is that as we're learning more, we're recognizing that there's still a good degree of protection. Now, to kind of generally speak about the variants, the concern is that over time, as the virus keeps mutating and having more and more variants, we're gonna get to a stage where the vaccines that we have now are not adequate, and we might still need boosters to have an additional level of protection. Sort of like with the flu vaccines, right? Like every year there's a variant that where we're trying to predict what's coming out and then getting a new flu vaccine based on the predictions. So that's sort of like the theory, is that with these vaccines, you still have a good degree of protection. You may not have the 100% efficacy and not having any symptoms, but you have a low likelihood for death and hospitalization, which ultimately that's like the most important thing, because you could, most folks are going to get over a mild, respiratory or disease and such. So while there's, of course, all of us are concerned about it, we really want to make sure we get as many vaccines in arms, because that's what's going to reduce the likelihood for the virus mutating. I hope that answered the question.
Yeah, and you know what? We have another question that really goes along with that. And could you share information about a booster vaccine?
Yeah, sure. So there's actually a few trials ongoing that are looking at modifications of the current vaccines. And here's the amazing thing about genetic sequencing. So as soon as you identify a virus, within hours, you can actually identify a genetic sequence and you can modify the vaccine just as quickly. That's what the brilliance and beauty of this next generation vaccinations and technology is. You're that quickly able to get your information, your sequencing, and followed by manufacturing. It might take you like longer to actually produce it because you're waiting for all the raw materials to come and all that stuff, as we're seeing, but you can have that ready within really days. So that's something just to kind of keep in mind. So the boosters, that's actually something that the companies are already starting to work on with the variants that are being seen. But that's the beauty of it, is just because how quickly technology has evolved, we're able to see that happen really, really fast.
And I think just to add on to that, I think that as time goes on, we'll learn more about the disease, more about the need for vaccination. We're not sure if there might be a future where we are continue to receive this vaccine until it no longer exists, as has happened for other diseases. So we'll still be learning about that. And I think with studies underway, we'll get more information on if these booster shots are something that is commonly recommended.
Okay. We had another question, and this is something you really didn't talk about. What are the chances of people under 18 getting COVID-19 now that many schools are reopening?
Yeah, I mean, that's, I'm almost done with my epidemiology degree. I have 1 month left. So this is something that we really think about quite a bit. And I think that the key to really answering this question is to understand the transmissibility in the community at the community level. So if you have parents and grandparents and those who are actually able to get the vaccine, getting the vaccine, you then have a degree of herd immunity. So, you can think of it as like, herd really kind of came about because of cattle, right? Like you have all of these people who are protected. So you have your young ones, like the kids going to school, who have this level of protection around them. So you don't have the spread between the older folks. And so you have kids who are then themselves protected within this cocoon. And so then they don't have the disease to then transmit it to other kids, right? So now if, let's just say one family didn't really want to take the vaccine and they came in contact with COVID-19 and that kid now has COVID, and then because they're asymptomatic, they go to their school and spread it to the rest of the kids. Now, of course, there's concern for transmissibility, right? So it's really about the degree of vaccination within communities. It's the degree of transmissibility of the virus spreading around in the community. So it's really hard to give a prediction for an individual part, like within Pennsylvania, like one community, without really knowing the number of folks who have the virus and the number of folks who are vaccinated. So the best thing we can do for our teenagers and our younger kids is make sure that all of us who are adults who are actually eligible to get the vaccine, because there's plenty of folks who are asymptomatic, and so they may not even know that they are making somebody sick, and so it's an unintentional negative consequence.
And just to add on with the vaccines itself, there are studies now that are studying it in younger kids, even as young as 6 months, that are underway. And so I think we'll have more information, and the data so far looks really good. And so I think that by the next academic year, we're looking at children being eligible to receive these vaccines as well. And I think that'll make us probably, as a society, we'll probably have more vaccinated folks across age groups. And I think that's going to be a positive thing, especially with us seeing schools reopening.
Okay, thank you. Because we're hearing about kids getting it in schools and kids who have had absolutely no symptoms. So they actually don't know that they have the virus, and then they don't know that they should be taking extra precautions.
Yeah, exactly. And I think that's why it's so important for us to all be wearing masks, because we just don't know, especially for those who haven't been vaccinated. We don't know if we're carriers, because not everybody is going to show symptoms. And so it's so important for us to wear those masks so that we're protecting everyone around us.
Okay. Here's another question that's related to that. What do you recommend the percentage of our congregations to be in order to achieve herd immunity? And I guess they're looking at a congregation as a community.
I mean, I think this is also a really good question, and it's something that Susan had presented in the one slide that talked about safest and safer and unsafe. And so, typically when we're thinking about herd immunity, we're thinking about the 70% number. And so if we are able to have 70% or more of the congregation vaccinated, that's the safest, because you have really a good number of folks within that congregation vaccinated. So I would say, 70% or to 85% or more folks vaccinated would be a really good, number. So, one thing I would recommend is, there's a lot of confusion about getting this vaccine, especially if folks are not used to technology. So one advice would be, check in on your neighbors, check in on your friends, see if people are vaccinated, if they know how to do it. And if you are able to help folks sign up, or, maybe even give them a ride to one of the centers that are vaccinating, that would be really amazing, because sometimes folks just may not have the access to the vaccine itself. So that would be my recommendation. But I would say, generally speaking, 70% or more would be a good number.
Okay. We've had another question, and this has to do with the future of really the vaccine development. Will studies continue that will move from emergency use authorization to attain full authorization for the vaccines, or is that necessary?
So the beauty about the emergency use authorization is it really focuses personnel to look at the approval process. So, I've actually toured at the FDA and talked about people at the FDA, and sort of understood the process for approval. And sometimes it takes months, right? But in the middle of a pandemic, we just don't have months, because if you're waiting around for months, you're losing more and more people, you're getting more and more folks sick. So having this expedited process for approval, where you're putting the number of personnel just focusing in on reviewing all the trial data, that's really the winning strategy when it comes to an emergency use authorization. So it's not that processes are being circumvented or bypassed, and we're just, without much thought, just giving, authorization. It's still being very much critically evaluated. It's just, you have a lot of dollars invested on people who are looking at the data. And so the processes, the red tape, you're kind of eliminating a lot of the process that you otherwise would have had to go through, because there's thousands of drugs waiting to be approved. So what's going to put your drug all the way to the top, right? But a pandemic certainly will, because we're trying to get the number of people who should be getting the vaccine or the drug or whatever sooner. So yeah, I mean, I think that full authorization, that's going to be obviously next steps with companies might pursue that. But ultimately, it's the same data that was being looked at. So I hope that answers that question.
Okay.
And just to add, a lot of times we're going to have post-marketing surveillance. So even after this, we're continuously studying these vaccines and the effects. And so for these companies to pursue further manufacturing after this pandemic is over, they will have to pursue further applications. So that is part of the process once a pandemic subsides.
Okay. There's a question about singing. What are your opinions about congregational singing softly if everyone is wearing a mask?
So, I mean, my opinion I mean, I love singing. Like, you know, we all grew up singing. It's something that Methodists do really well. So, you know, I kind of appreciate the question, because who doesn't love beautiful music, right? So we all want to sing, we want to hear each other sing. So my general thought about this is, while we have a pretty high degree of infectivity within the community, you know, we could maybe consider humming, or, you know, sort of not producing as much aerosolization. So atomization of particles, in case there's any of us that are infected, right? So generally, I would probably recommend humming as a strategy, because you're kind of keeping in your potential, you know, particles if somebody were infected, just to protect everybody else. But certainly, if the community itself has low infectivity, good vaccination rate, I think singing softly is not a bad idea. But if you really wanted to be extra careful, I think humming is probably a safer approach.
Okay. And we have a final question that has to do with newer modified vaccines. And will newer modified vaccines be needed to fight new developing variants over time? And will the development of variants be continuous for an indefinite time, or do you think it's going to come to an end?
I think the variants are going to, just because of how viruses are, I think we're going to see continuously the variants will be developing. And so I think because we know the sequencing of this, the virus itself, we can develop it, we can develop the vaccines in a way that we can combat it. And so I think potentially, depending how long this pandemic goes for, and if we cannot get it under control in the time that we need it to happen, I think we will see development of vaccines. And thankfully, because of the technology that Elson had talked about, we have a faster way to make those changes that are necessary in order to take care of that.
Okay, so our technology is actually what's going to save us, the development of the technology. And thank you, doctors, for pointing out and describing that technology so well.
You're very welcome. I mean, all of these questions are, you know, really valid, and I'm really actually impressed, and I love questions and people who are really being thoughtful about their healthcare, because ultimately it's our bodies and we should be thinking about this, and we should be critical. We should question everything. And I think that's, you know, amazing that people have really such thoughtful, wonderful questions. And, you know, I know that, you know, folks may have to jump off, and I'm happy to answer any questions that may come up even after the talk, and we're happy to stick around too. But, you know, it's really, really amazing questions. And yeah, I agree with you. Technology is beautiful. And I'm so excited that, you know, we're seeing such the pace of science as the way it is.
We want to give thanks for Brenda, your willingness to lead the Q&A, Dr. Elson Jacob and Dr. Susan Jacob. It has been an absolute gift to have you tonight. And I want to turn to Reverend Jessica Ross as she's going to close our program tonight in prayer. But deepest thanks from Bishop Peggy Johnson, the Office of Connectional Ministries, and all who are able to be here tonight. There are many who are not here and are so thankful that you were willing to record tonight. So for those who are on this evening, the recording will be made available to you later this week. And so look for that on epaumc.org. Many, many thanks. Pastor Ross, I will turn it to you. And you just want to unmute.
Here we go.
Yes.
All right, so you can hear me? All right. All right, praise the Lord. All right, thank you very much, everybody. Just wonderful, wonderful. Let's go to the Lord in prayer. Dear Lord, we thank you so much for who you are. And we know, Lord, we just can't say thank you enough. If we had 1,000 tongues, we couldn't thank you enough. And we know, oh Lord, that you are ever present. You are ever present help in a time of storm, and you are our strength and shield. And you know what we need before we know ourselves. Thank you so much for our experts, Dr. Elson and Dr. Jacobs. They so eloquently, clearly explained in concrete terms all we need to know. Thank you so much for the opportunity to share the truth that we have learned. I thank you, Lord, for everybody involved in making this happen. Dear Lord, we praise your holy name and ask you to heal all of those who are hurting. Heal the divisions among us. Release us from all our fears. Open our minds and hearts to scientific facts. Grant us the courage to trust that you, Lord, have provided these vaccines so we can trust that you, Lord, are working on the inside to protect us from what's outside. Help each church be on one accord regarding masks and following all safety protocols to keep them in place, oh Lord, for everyone's safety. We pray for that herd immunity that's necessary to keep ourselves and our world healthy, and so that we are ever able to always praise your holy name. In Jesus' name I pray and thank you. Amen.
Thank you so much. Good night, dear friends.
Good night. Thank you.